So this was our case today. I took this from Mark. This is the uveitis. This is inflammation of the uveal tract consisting of the inner vascular coat of the eye, the iris, the ciliary body, and choroid. We should know the parts of the uvea. That is the iris, the ciliary body, and choroid. Iritis may occur alone or in conjunction with the ciliary body as iridocyclitis. So iris plus ciliary body together, we call it as iridocyclitis. This commonly occurs insidiously without symptoms. It can start with, it can be gradual, and in the starting there won't be any symptoms. Okay. The next is children with seropositive ANA arthritis are high risk group for uveitis and need to have regular eye reviews. So ANA positive arthritis, the children who are, they are more prone for uveitis and need regular eye reviews. So case Jane is well looking 8-year-old girl. She appears Cushingoid. Examination of her eye reveals conjunctival congestion. The visual acuity of her left eye is markedly reduced. I made it right, but here it's left. It was not possible to examine visual fields. The pupil responses are present but slow on left. They are present but slow. That means here it is not due to the palsy of the nerve. It is due to the inflammation of the iris. There is slow movement, can be due to pain. Okay. Slow. The pupillary responses are present but slow on the left. Ophthalmoscopy reveals clouding of the cornea on the left. There is normal visual acuity in the right eye with normal pupil response and no clouding of cornea. This would fit with chronic uveitis. I would like to proceed with full systemic examination, paying particular attention to the joints and looking for side effects of steroids. So after the steroid toxicity and glaucoma, second put uveitis, then you can put other things down as differential. This is what I want to tell. So anyone wants to tell anything about this? We should know about, because JIA can come in history station as well, and also it can come in the video. We should know the diagnosis and management properly. Okay. We will just only go through the investigations and management. Rest all we can read ourselves, because this will be the main thing which will be asked for us in the exam. Okay. So there are no diagnostic tests for JIA. It's a clinical diagnosis. Then laboratory is full blood count you will do, and you will do ESR, CRP, which is oftenly elevated. Okay. So ANA, if positive, is associated with increased risk of uveitis. So whenever you suspect JIA in a child, we have the criteria, which we will read by ourselves later. So you will do the CBC, you will do ESR, CRP, which is often raised, and ANA, if it is positive, it will give you the increased risk for uveitis. Okay. Other things is the rheumatoid factor and HLA-B27 are useful classification, because HLA-B27 is positive in 90% of enthesitis related JIA. So other things you will do rheumatoid factor and HLA-B27. Next is the viral and bacterial serology if history is suggestive of post-infectious arthritis. So in the investigations, let's all remember CBC, which is common, CRP, ESR, which is often elevated, ANA, because if it is positive, you will think there is risk of uveitis, and before even the symptoms, you can refer to the ophthalmologist to see, because it will be a gradual process. Maybe the child may present for you late. If the ophthalmologist can see, and if he needs early, he can treat them early to prevent the loss of vision. If ANA positive, it is associated with increased risk of uveitis. You'll do rheumatoid factor and HLA-B27. This is more, HLA-B27 is positive in 90% of this enthesitis related JIA, and viral and bacterial serology only if you suspect post-infectious. Then what are the imaging? X-rays are normal in early JIA. It is useful to exclude trauma and osteomyelitis or malignancy. So ultrasound can show joint fluid, synovial hypertrophy, and erosions if present. MRI delineates any bone changes, joint damage, and extent. So if it is early, maybe the X-ray may not be helpful for you. You can tell in the imaging, X-rays, ultrasound, and MRI. So what does ultrasound will tell you about the joint fluid and any synovial hypertrophy and erosions? MRI, any bony changes, joint damage, and so clear picture you will get from the MRI. Okay, you'll get the clear picture from MRI. Next, aspirate the joint if septic arthritis is suspected. So let's go to the management. Management, always divide yourself into non-medical management and medical management. This is very important here. Okay, so let's go to the non-medical management. Non-drug management includes physiotherapy and occupational therapy to maintain the function and prevent deformities. So you will tell physiotherapy and occupational therapy in your multidisciplinary team management. And hydrotherapy can be very beneficial. Okay, hydrotherapy like swimming. So what? Physiotherapy, occupational therapy, hydrotherapy. Then patient should be encouraged to participate in as much physical activity as possible, including most sports and dance. Regional pediatric rheumatology service will provide more specific advice. So you will refer to the rheumatologist, pediatric rheumatologist. So affected children and adolescents and their families typically need support with long-term medication and the impact on family, social, and school life. So you will tell the social support, okay, and also educational support. So they need support with long-term medication, impact on the family, social, and school life. So social and psychological support, and even the school nurse and school will be involved to know about their condition. Expert multidisciplinary teamwork, including physiotherapy, occupational therapy, clinical psychology, play specialist support is essential. Untreated chronic inflammation can lead to growth failure or abnormality, osteoporosis, and delayed puberty. So if the treatment is not given properly, they can have growth failure, osteoporosis, delayed puberty. The use of systemic corticosteroids is now much more limited due to availability of other treatment options. So we should know the recent one. That's why I'm reading from here. In Mark, I feel the starting things is good, but for the treatment, we have to choose something which is important, either NICE guidelines or any recent book. Okay, that's why I'm reading the management part from patient info. Drugs, NSAIDs for symptom relief, then steroids, Steroids, you have either intra-articular steroid injections for affected joints, then systemic steroids for quick symptom relief and systemic disease. These can cause growth suppression and bone demineralization if used long term. So topical steroids for eye involvement. So steroids is everywhere. Intra-articular for the arthritis, topical for the eye, and systemic. Okay, and you see good response, but at the same time you should be aware of the steroid toxicity. You have to tell this. So now this sentence is very important. The use of systemic corticosteroids is much more limited due to availability of other treatment options. So we should, along with steroids, we should tell other treatment options. Okay, so methotrexate, first line treatment if multiple joints are affected. Here he is telling first line treatment if multiple joints are affected, or if the same joint requires injecting more than 3 times. Means if the same joint needs multiple injections of steroids, you will go for methotrexate. And also nowadays it is the first line treatment. If multiple joints are involved, you will start with the first line treatment. It is often given as subcutaneous injection. It requires regular blood test monitoring. This is, you have to, at the same time when you tell methotrexate, they may ask, what do you want to monitor? So as with the adult rheumatoid arthritis, there is evidence to support its use in early polyarticular JIA. Okay, so you can use methotrexate, but they needs regular blood test monitoring. Can someone tell me what are its side effects? Why they want regular blood test monitoring?
Bone marrow depression.
What? I can't hear.
Bone marrow depression. Huh?
Okay.
The platelets, blood count will be reduced.
Neutropenia.
Okay, I heard bone marrow depression. Someone else also was speaking something. What?
Neutropenia.
Neutropenia. Okay. Next is the sulfasalazine and leflunomide may be used in JIA. So, but main go with the top 3. One is the NSAIDs for symptom relief, steroids everywhere. You can remember steroids everywhere, like eyes topical, intra-articular, and also systemic. But nowadays, if first line can also be methotrexate direct if there is multiple joint involvement, or if one joint you are giving repeated steroid, but they will choose methotrexate. Okay, but you have to do blood monitoring of the blood test if you use methotrexate. Next is the Etanercept is licensed for those patients with polyarticular JIA. Please take care of mics, please, please, please. Okay. Etanercept is licensed for those patients with polyarticular JIA for whom methotrexate has been ineffective. So if methotrexate is ineffective, the next choice is this drug. It is the only anti-TNF licensed in UK for JIA. Okay, I don't know whether they will go so deep or not. Just at least we should know NSAIDs, steroids, and methotrexate. Then he's telling this is the only drug. Etanercept is only drug licensed in UK for JIA. It is in the patients where methotrexate is ineffective. Tocilizumab is approved by NICE for the treatment of systemic JIA when steroids and methotrexate have failed and may be used in polyarticular arthritis. Again, if we get SJIA, that is as the video station or something, this question can come. Okay, when steroids and methotrexate have failed, which drug can be used? Okay, so just remember 3-4 drugs name. After methotrexate, we have to remember this etanercept and tocilizumab. I think more than enough. Other drugs used off license include so many things and other forms of anti-TNF blockage, but funding needs to be approved. So all these things is not needed. First 3 is the most important, which you will tell. If the examiner finishes there, it's okay. If he goes to add, just remember 1 or 2 extra names. That's it. So surgical intervention such as joint replacement or synovectomy may be required. This is as a last resort, you will tell. So complications are very important in this cases. So joint deformities, knee flexure contractures. Okay, just know the joint deformities and also uveitis. So our case is uveitis. A serious complication is uveitis, which can lead to blindness. So 30% of those with oligoarticular JIA associated with positive ANA. So ANA will be your basic test if you are suspecting JIA, because 30% of oligoarticular JIA is associated with ANA. Insidious and asymptomatic. It often affects both eyes, not linked to arthritis. Okay. Next is the osteoporosis and growth restriction. That's all. I think enough. We should just know at least the names of few drugs, and non-medical management is very important. Physiotherapy, occupational therapy, hydrotherapy, psychological support, rheumatologist involvement. Okay. So anyone wants to give any comments before we end? Yes. Or there is any other source, good source, which is more easy to remember anything? Anyone else read from any other place which is easy can tell me. But I just want to ask, what is given in mark, the classification oligoarthritis, polyarthritis with, I think, rheumatoid factor positive and rheumatoid factor negative. It is same, right? Is there any new changes in that? Anyone can tell me? Are you people listening to me? I don't know. No one is answering. Hello.
Yes, listening.
Yeah. I don't know. The classification there is good. I did not read from any other book. I'm just asking if there is anything new or recent or anything. Okay, let me read some important points from the chat. Okay, nothing much. I'll just, Dr. Kumar has written neutropenia. If neutrophils less than 500, should stop methotrexate. Okay, this is the side effect. Okay, thank you everyone. I hope it was a nice session.